what is the concept? Why do we want to look at the viability? The idea is that if you have ejection fraction which is poor, and then you're going to land up with the difficulty doing a bypass surgery, you need to justify surgery. Would the patient recover? And, is it worthwhile taking the risk of the surgery? So we want to revascularize patients, those who would benefit from surgery, and over and above the benefit of the problems of the surgery. We have no doubts that patients, those who have angina, they would benefit from surgery. Number of studies done to actually evaluate this, and that's what I'm going to discuss today. And there are various parameters which evaluate the way we do viability. Viability is basically that you want to prove by doing any investigation that the cells in that kind of not moving myocardium are alive, and they have a potential recovery once the blood flow is restored. Hibernation is the same thing, but it's in retrospect. Retrospect means that if you do a bypass surgery and you find that the segment which were not moving start moving, you say it is hibernation, right? It's one and the same thing. Viability, I'm checking the same thing in prospective manner. As a normal myocardium, with very less of the glycogen store, because it uses free fatty acid to run. But in case plenty of glycogen stores are there. But let me tell you, the myocardial cell don't die as such as a single unit. There could be disintegration of various components of a myocardium before it actually dies. In some, the mitochondria would disappear first. In another, the muscle fibers would actually disintegrate in the cell. So now what happens when there is a sudden occlusion of the supply, there is a stunning of the myocardium, then repeated damages, ischemic damage is done to the myocardium, produces hibernation, and there is less organelle you can see, and then it leads to fibrosis and a complete scar. And that's the stage when nothing can be done. So we want to find out that patient is with scar or some viability there. There are ways of doing it. One way of doing it is that you find there is a membrane integrity, whether membranes are there, cells are alive. How do we do it? Thallium behaves like potassium, enters into the cell, enters into the myocardium. If it shows that it enters there, it indicates the cells are living. Two is that you find out that there is an extracellular volume which is more in the same. That means more extracellular volume, less cells. Indirect. Third is, are there cells using oxygen, glucose, or they're using free fatty acids? Ischemia and viability. But the best is you show on dobutamine stress echo that yes, they can contract. Okay, so that's the direct evidence of viability. And angina is a very good clue that this is a viable myocardium. Only living cells would cry. A presence of a Q wave, I will discuss. ST elevation on a treadmill test, dobutamine, SPECT, PET, and MRI of the heart all can give you the same answer of viability. But again, in India also the cost comes very important, and the sensitivity specificity also is important. DSE is most prevalent available. It's very, very cost effective way of doing it. It's more sensitive. You can look at here, if comparing apples and oranges, and you see our friend dobutamine stress echo has a very high sensitivity, though the specificity is not as much. Q wave itself in the ECG does not really indicate that the muscle is dead. 60% of the patient, those who have a deep Q wave, would show a viability. ST elevation in the leads where you have a Q wave or a minor ST elevation to begin with, there's an increase in ST elevation. It gives you quite a bit of clue about the viability. And thickness, again, if the myocardium is less than 5 millimeter thick, high likely that this myocardium doesn't have good cells living in it. And that's again, if you do a thallium uptake plus the thickness of the myocardium, they do give you an idea. If it is less than 5, it's unlikely to be viable. And that's one case where you see there is an apical and anteroseptal and septal segments, akinesia, and with the thinning of the myocardium. And I don't expect this by on the measurement. This was about 4 millimeters. So I don't expect there to be a large viable myocardium there. As compared to this patient where posterolateral or posterior segment, mid posterior segment showing akinesia, and but its thickness is maintained. So I do expect a lot of viability there. Dobutamine stress echo as a protocol, we generally don't go beyond 15. Some people have done about 20 microgram per minute per kg body weight, but we begin with stage 1, 5 microgram, stage 2, usually that's enough, but many times we need to go to stage 3 to look up the viability. The segment, more than one segment should actually start moving to say this is a viable, and then you have a viability index, that how many segments are not contracting to begin with, and they start contracting now. Then that's an index of we can do that gives you the severity of the problem. Administration of nitroglycerin actually tends to improve the viability by dobutamine stress echo, and there are newer molecules on the horizon which can actually replace thallium dobutamine, because they do not produce increase in blood pressure, which many times undesirable with dobutamine. What do we get once we do dobutamine stress echo? We get biphasic response. It's contracting something, starts contracting more, but actually goes into hypokinesia again. This is a biphasic response typical of a viability. Sustained, you can have a continued contraction, right? Continued improvement right through doses of dobutamine. This again indicates viability. Or you can have no change. Worsening of the regional wall motion normality again also indicate that something is living there. We need to improve on this plane. All the cases I'm going to show you by biphasic, and this is courtesy Dr. Nitin Burkle, who uses contrast in almost every patient. I think my pointer is not working here, but if you could see the panel, the very first slide, the pointer was required here. Can we have a pointer, because I wanted to show the arrhythmia here. The apical septal segment, if you see it starts contracting well and goes back. Yeah, that's good. So now this starts contracting better with low dose dobutamine, goes back to the same situation, indicates that this is a biphasic response. Another biphasic response, you see the contraction here, improvement in the contraction, goes back to the hypokinesia again. This image is not too good, but you can actually see there is no improvement in the lateral wall. More than that, you can see these segments are not even perfused well. You don't see any contrast going into the myocardium. You can have worsening of the mid-posterior segment shown here. This also indicates the myocardium is ischemic and viable. So one of the studies shows that very good number of segments, and showing that on a dobutamine stress echo, the segments which improved had a viability, did better in the long term after revascularization. The salvi size decreased, the stroke volume decreased, and ejection fraction improved. And the improvement, as I showed you, the viability index, more is the problem in the viability, larger are the number of segments, more improvement you can expect in ejection fraction after revascularization. So this was a meta-analysis done of 24 studies on viability study using different techniques, large number of patients in total. Ejection fraction was low, and then you can, all these trials you can see there was an improvement with the if you have a viability, the revascularization death rate was quite lower as compared to non-viable myocardium. So number of non-randomized trial showed improvement in the bypass or PCI where you revascularize, and that's an improvement. This came as a shock. Randomized trial, in particular the stitch trial, said viability or no viability doesn't make a difference. So what were we discussing? Anyway, so that's exactly what happens. You start up, there is an initial enthusiasm that you found out a good technique. You do a reality check, and the reality check, and then you say we need to improve what we were thinking. Right? The startup was that we did have plenty of trials which showed improvement in the outcome if you say this myocardium is viable. The randomized trials actually gave you a shock, and then with the recent learning we would tell you that what is the current guideline, that what should we do in the current scenario of those shocks what we had. So stitch trial, which is the main trial which shook us, had a lot of caveats, and I would discuss that, and more trials are underway. So the concept with the stitch trial was the surgical treatment of ischemic heart disease. We wanted to find out CABG in heart failure. Now, previous trials, only very small number of patients had, ejection fraction less than 40. Most of the patients had angina. So you have angina, you don't need viability studies, right? The two hypotheses we wanted to say, LV dysfunction and coronary artery disease, if we revascularize versus intensive medical therapy. We've grown up in medical therapy also, right? The secondary hypothesis was the impact of the viability. So these were two hypotheses which they went with. About 1200 patients divided into 600 each roughly with the bypass surgery and not bypass surgery. The caveat was the viability assessment was done in less than 50% of the patients. This was a subgroup analysis, and the viability choice was given to the enrolling center, so that which patient required viability study, which patient did not require viability study was a choice of the physician. So this introduced a bias in the study. So we do see that whether the viability of myocardium is there or whether the viability is not there, CABG was a shade better than no CABG with viability, with no viability. Both. Now, same, if you do bypass surgery and you do a medical therapy, CABG was a shade better than that. But if you compare with the viability study, there is no difference between with the viable myocardium or without viable myocardium. They almost were the same. Then what happened to those patients, those who had improved ejection fraction after bypass surgery? Okay, so we expected that their mortality would be lower. No, that also was not true. So what we now come to conclusion here from that trial, that you do a medical therapy or you do a bypass surgery, you do an improvement in the functions, but with viable myocardium or without viable myocardium doesn't make a very great difference. Recently, this is published in October itself, that we did a PCI in patients rather than bypass surgery. We thought that possibly bypass surgery has its own mortality, morbidity, and let's do an angioplasty and open the arteries and see how do we do in this category of patients, right? And in this category of patients, I would go back, there was again revascularization. PCI did not impact the death or hospitalization. Okay, which actually means that we've gone quite high on medical therapy, and the comparing these two are not making a very great a difference. So caveats in SIS study was the viability was optional, less than 50% were done viability study, and the viability index was low. You need a quantum of viability to say that it would improve. The index was low, and they used different modalities to do this in different patients, which again could have introduced a significant bias. So currently we do have guidelines of revascularization from ACC last year. The presence of viability predicts outcome. Whether you do bypass surgery or you don't do bypass surgery, patients, those who have a viability, they have a better outcome than those who have no viability. So this much we can say: those who have viability, they improve. Myocardial viability, I'm sorry, alone may not be the deciding factor. You need to include other areas. So another thing, you should not say benefit of CABG would not occur in patients those who have a non-viable myocardium. You have a revascularizable patient with a low ejection fraction. It's still a good idea to do a bypass surgery whether you have viability or you don't have viability. Other important factors are, the vessels itself, the age, and LV volume. So these are the current guidelines on that. And I have a small proposed algorithm based on the guidelines. Now, first thing you decide, is it revascularizable or not? So first is an angio. If no medical therapy, understandable, no question there. If it is revascularizable, then if the patient has angina, there are ECG changes, or imaging shows a viability, then you should go either medical therapy or revascularization. This is medical therapy plus revascularization. If there is no ischemia, the tricuspid scar is thicker. If it is thinner, the lesser myocardium is viable in that. This we can do it in CMR. And in case it is in between 25 to 50%, we can go for a contractile reserve or the myocardial viability. In case the viability is there, then we can go ahead. So primarily we've diversified here only that if you see the revascularization, it is possible to revascularize. It's good to revascularize right in there and then. And please don't declare the stars are not seen, because they may be there. The sky is cloudy. Thank you very much.